All right, once again, thank you for joining us today. My name is Matthew Menendez with White Plume. I certainly appreciate you spending part of your afternoon with me. I hope that this will be valuable, helpful for you. We are recording the webinar today, so if you need a link to the recorded version, feel free to let me know through the questions panel. I'll make sure that we get that to you either later today or tomorrow. Here's what I want to do. Let me give you just some background information on what I hope to accomplish over the next 30, 45 minutes with our time together today. The first thing I want to do is look at where we've come from. When you're heads down doing a lot of work, doing a lot of hard work that's happened in the healthcare industry over the last 5, 6, 7 years, sometimes it's easy to get caught in the details and forget about what's happening. And we've been through a lot in the last 5, 6, 7 years in healthcare. I would call that the meaningful use era. There was a lot more going on than meaningful use, but that was the big driver of what was happening in the industry. I would highlight a lot of that was government regulation and government change, government enforced programs. So we had that with meaningful use, we had that with PQRS, we had that with ICD-10, right? That was a big change. It got delayed a couple of times, but it finally arrived as well. We had the Affordable Care Act. There was a lot of change that was difficult. It was difficult on patients, it was difficult on providers, and it was very difficult on the staff in a practice that supports those providers, both the clinical staff and administrative financial staff. So we were operating in a high change environment, right? I think many people would say they are tired of change. It feels like everywhere we looked, there was change. And one of the really hard parts about that is we had to deal with a lot of these new programs and add a lot of work onto our plates and onto our staff's plates without a lot of extra reimbursement. You know, some of the programs had some incentive money that was associated with it. But I think now that we're on the other side of that and we're looking backwards at it, you know, we would say that the government incentives, you know, barely paid for all of the change and all of the costs that we have. That's hard. And we just need to pause for a second and recognize how difficult that's been for most people, how hard that's been over the last 6 or 7 years. And then as we start to look forward, we see that there are more changes on the horizon. Right? We've got QPP and MACRA and MIPS that are going to try to fundamentally shift the way that we're being paid away from the traditional fee-for-service, volume-based reimbursement world and move us into a value-based reimbursement world. And we're right in between those two right now. And all the change has been really hard. And I think we all need a win right now. We need a win for our doctors. We need a win for our administrative team, for our revenue cycle process. And we need a win that doesn't require a lot of change or a lot of risk. And we need something that's going to work, that's proven. So I want to spend a little bit of time today unpacking those 3 categories, showing you some of the work that SRS and White Plume have done together to try to deliver a proven solution that has a very tangible return on investment with low change and low risk to our mutual clients. And I'm going to show you what that looks like. I'm going to make sure that I leave time at the end for questions and answers. So again, if you're just joining us, welcome. Feel free to use the questions panel as we go. And I'll try to answer as many of those questions at the end as I can. Okay, so what's been happening if we zoom way out and look at what's happening from a big picture perspective? CMS and the other payers are following suit. They are trying to accomplish, they are trying to deliver on the triple aim of healthcare. This is a lofty goal. It's not going to happen overnight. And it's trying to simultaneously deliver better care and lower costs and an improved patient experience. Right? All of those things are good things. They are noble goals. They are worthy of being pursued. But the government can't do that by themselves. They need help. They need to engage patients, and they need to engage providers, and they're trying to do that. They're trying to do that, but the way that they've gone about it so far has been messy. You know, change is always difficult. It always takes longer than expected, and it's always hard, particularly on the people that are being changed. And so when they've engaged patients thus far, here's what we've seen. We've seen higher premiums. We've seen higher deductibles. Who likes that? Nobody, right? This has seemed to be an annual event for our employees. We get the Blue Cross notification about this time in the mail, and premiums are going up 6 or 7%, right? That's better than it is in a lot of other places, but they're still it's getting more expensive, right? And part of that is by design to try to get patients to engage more in their healthcare decisions, take more responsibility. But that's not a win for patients. That's not what patients want, right? All of the patient engagement, you've fought this battle over the last 5 or 6 years trying to get patients signed up and to log into the patient portal. That's not an easy thing to do. And what about the provider side? You know, the government programs under meaningful use, under PQRS, right? The risk-adjusted costs and quality measures that are coming under MIPS. Following government programs is not why most physicians got into medicine. That's not what they want to do. And so these things feel like a loss for patients. They wouldn't say that's a good thing. They wouldn't say it's made their life any better, right? It feels like a loss for physicians. This isn't why I got into medicine. I feel like I spend more time at the computer putting in data that doesn't necessarily help my patients. That's not why I spent years in medical school. It feels like a loss, right? I'll share with you just a quick study that was done. The Journal of Participatory Medicine in 2015 published this study that asked the question, what do people want from their healthcare? What do patients want? That's exactly what you'd expect. This is not new news. They want physicians who listen to them. They want physicians who explain things clearly. They want physicians who are caring and compassionate. That's what patients want. And I bet most of your physicians do a good job of that. That's what they're passionate about. That's what drove them to want to be a physician. What about doctors? What's happened to them? Another study that was done, this one was done by the Mayo Clinic, again in 2015, looking at physician job satisfaction, physician burnout by specialty, comparing 2011, that's the purple bar, to 2014. And you can see physician burnout increased in every single specialty during that time period. Right? That's not a win. That's a loss for physicians. The government regulatory environment that we've been in makes that difficult. Right? Again, I'm not telling you anything you don't already know. We're going to get some of that control back. We get a little bit of flexibility back in MIPS. How do we take some of that control back to give our doctors a win? To give our staffs a win. Let me show you this, looking at our office staff. Do you remember what it used to be like? Think back maybe 5 years, maybe more, what it looked like. Let's we'll take our example today. We'll look at a 15-doctor practice. They see an average of 450 patients per day. And here's what used to happen. Doctors would see the patient, and it's typically the doctor, sometimes maybe an MA or a PA, would communicate information to the coding team, the billing team, the revenue cycle. They would typically do that on a paper super bill. Fast and easy for them. Got the billing team all the information that they needed. Coding and billing team would need to get that information into the practice management system. They would typically key that in. It wasn't straight heads down manual entry. All right, there was some thinking that was going on. You can see my little Einstein back there. They were thinking. They were following all of the different insurance rules, making sure that it was on 2 lines with an LTRT for my Blue Cross patients and 1 line with a 50 for my Medicare patients. They were making sure we had diagnosis codes that made it medically necessary, jumping through all the hoops and hurdles that the payers required to get the claim paid. And it didn't take a lot of time, maybe 15 hours a day for an office who's really fast, really good at this. And then meaningful use came along, right? And what happened with meaningful use was we added work to the clinician, right? This wasn't the fault of the EHR vendor. Meaningful use was requiring all of this extra data, some of it the same information, to be put into the EHR as well. And that wasn't good for the physician, right? I don't want to put this information in 2 places. I'm not going to put this information in 2 places. This is killing me. It's making me see fewer patients. They won't do it, right? This was an industry-wide complaint during the meaningful use era. And so you know what happened? I'm sure this happened in your practice, is that loss got shifted from the clinical staff to the front desk, or to the coding team, or to the billing team. Somebody else had to enter that information, not just into the practice management system, but enter that into the EHR as well. So we had a 60% increase in the amount of time that was spent to get that data where it needed to go, but no additional reimbursement for that. Right? So we had the losses kind of pile up, right? It's not, we have stuff going on that's bad for patients. We have stuff that's going on that's bad for doctors. We got stuff that's going on that's bad for our office staff as well. And that's where we say we got to have a win somewhere. Help me out. Where can we make some improvements for our practice? Right? And that's really where we've kind of SRS and White Plume have been working on this together, because we know that the meaningful use era was hard, and we know that more change is on the way. So how do I find something that'll help me with some of my problems today and set me up to be successful as we make the shift from volume to value? Because that's what's going to happen under MACRA and under MIPS. Now this year's a transition year. They made that very easy to avoid the negative adjustment in 2017. I'm going to talk a little bit about that, because some of those changes that are coming, we're going to want to be able to help you with that as well. So let me show you what's happening. Again, let's zoom out and look at, this is the CMS payment taxonomy framework. That's a lot of fancy words that Medicare put out as kind of their roadmap. Here's what we're trying to do. They're trying to move us out of fee-for-service and into value-based reimbursement. Most of that framework is still built on the fee-for-service architecture today. What that means is fee-for-service is not going away. It's just going to be used for payment modification. So you're still going to have to do all the work for fee-for-service, but they're going to make adjustments on your fee-for-service reimbursement based upon your quality measures, based upon your resource use. You know, right now, majority of people are still on the left-hand side of this slide, but CMS is trying to move that to where by 2018, 50% of the Medicare payments have a closer link to quality. Right? That's what they're interested in. I don't have time to go through all of this slowly with you. If you've got questions on it, I'm happy to answer them. This is just another data point that tries to prove the point that CMS cares about cost. They care about quality. This is the QRUR report. If your practice has participated in the value-based modifier, you've probably seen this before. But this is another attempt by CMS to measure cost and to measure quality and compare you to your peers. Right? Nobody wants to be in that bottom left quartile where you're low quality, where you're high cost. Right? That's kind of the double whammy. Nobody wants that. And CMS long-term wants to be able to publish this data so that patients have access to it. Right? Another place where CMS, you can see their focus on cost and quality, is when you look at the MIPS categories. It's just a quick breakdown of what the MIPS category weights look like over the next 4 years. And again, what you see, what I notice when I look at this, is 60% of my score is tied to cost and quality. Those are the two biggies, right? Yes, you have these clinical improvement activities, and yes, you have advancing care information, but 60% of my score, the lion's share, is tied to cost and quality. I think this is the easiest way I can break it down for you. It sounds very simple. Medicare and the commercial payers as well are saying, we want to measure and we want to pay you based on quality and cost. That's where we're headed under MIPS. That's where we're headed under QPP. And the pushback from the physician community has always been, you don't understand. My patients, the people that come to our practice, are sicker than the average patient. We see some of the sickest patients. We see some of the toughest cases. And so it's not fair to measure our outcomes relative to our peers. It's not fair to measure our costs relative to our peers. If you're going to do that, you have to control for patient acuity, for how sick my patients are. And so what CMS has said is, okay, prove it. Okay, we will do risk adjustment. We will take these cost measures, we will take these quality measures, we will handle the patient acuity through risk adjustment, but you've got to prove it in the data. Right? So data is going to become much more important than it ever has been before. You know, again, I know I'm moving through this quickly. If you've got questions, I'm happy to talk through the questions that you have with you. But let me show you what is happening from a risk adjustment perspective already. That about 18% of practices across the country are familiar with this. So most of you may not be. There is a preferred government methodology for risk adjustment that they've been using since 2004. It's called HCC coding. Originally, it was used for Medicare Advantage plans, but they've really broadened that out as we've had more and more shift towards value-based reimbursement. There continue to be more places that the government needs to use risk adjustment, and every time that comes up, HCC coding is the model that they use. So the way that HCC coding works is there are two components. It's demographics plus diagnosis equals HCC score. Demographics plus diagnosis equals HCC score. And so what that means is the demographic components are age, gender, and eligibility status. Pretty simple, pretty straightforward, but the diagnosis component is where things get a little bit trickier. They use the diagnosis codes from the past 12 months for that particular patient, and different diagnosis codes have different weights to them. Basically what it means is the higher your HCC score, the sicker your patient. The sicker your patient is, the more Medicare expects to spend on that particular patient. The more Blue Cross expects to spend on that particular patient. Okay? Just a quick example that might be helpful for you. If you look at a 76-year-old female patient who is eligible for Medicaid, right? You can see that her HCC score is 0.593. That means that Medicare expects to spend $5,300 on that patient over the next 12 months. Pretty simple, pretty straightforward. Now, my coding wasn't so good. We didn't capture some of her chronic conditions. And you can see what happens when I capture some or all of her chronic conditions, how that impacts her HCC score, how that impacts her expected cost over the next 12 months. Makes a big difference on one patient. Imagine what that would look like if that was happening across your entire patient panel. So as Medicare and the commercial carriers make the shift from volume to value, as they start to want to measure quality, measure cost, and they want to do that in a risk-adjusted way, it matters how sick your patients are. But sometimes there can be disagreements between what you think your patients look like and what the payer thinks your patients look like. You think your patients look relatively sick. Your payers think they look relatively healthy. How do you explain the difference between those two perceptions? Or how do you explain the difference between the payer's perception and your reality? The difference is in what you code. Because the places where the payers are getting all of this information, they're getting it from the claims data. That's where CMS gets all of this information. So what you code matters much more than it ever has before. I'll give you just another example that may hit a little bit closer to home. Let's imagine I have 3 identical patients. They all need total knee replacements. Now, under the fee-for-service world, what would happen is, as long as I had a diagnosis that made it medically necessary, it didn't really matter. So I might code unspecified osteoarthritis for an unspecified knee, right? There is such a thing in ICD-10 as an unspecified knee. I've never seen a third knee. I've only seen left knees and right knees. But the code exists in ICD-10. It was one of those codes that was supposed to get denied. Medicare gave that grace period for unspecified codes. They really haven't started to crack down on that as much as everyone expected. But we still expect that will come in the future. But that patient to the payer looks relatively healthy. All right? In scenario 2, identical patient, we code primary osteoarthritis of the left knee. We've been a bit more specific in our primary diagnosis. But we also coded that this patient is morbidly obese, right? They are overweight. They have a BMI greater than 40. That's causing some additional stress, strain on that knee joint, which is one of the reasons why they need the knee replacement. That patient, the gap between what I think that patient looks like and what my payer thinks that patient looks like has gotten much, much smaller. But it's not all the way there, because I left off that they also have type 2 diabetes with polyneuropathy. Right now, I've got an accurate representation of what my patient looks like. Now that's matching up. Under the fee-for-service world, they were probably getting paid the same way, and they may still be getting paid the same way today if this payer has not cracked down on those unspecified codes. But the HCC score is very, very different. The patient acuity, very, very different. How much Medicare expects to spend on this patient compared to an average patient is very, very different. So think about this. When you start to get measured for your quality outcomes, it matters how sick your patients are. Those measures are risk adjusted. When they start to measure your cost for a particular episode or the total cost for a particular beneficiary across the entire system, it matters how sick those patients are. And for most people, this is not something that they're paying a lot of attention to today. I borrowed this slide from a Blue Cross Blue Shield plan in Michigan that was doing a presentation to their Medicare Advantage providers. And I think it's right on. We haven't had to deal with this. A lot of people, doctors don't want to be coders, and I don't want to make doctors coders, but I want to point out some of the changes that are coming under MIPS and under MACRA, some of the things that we'll need to start thinking about, because it is important to get those comorbidities properly documented and coded. Right? You may not need that for your fee-for-service reimbursement today, but as we make the shift to the value-based reimbursement world, that's another thing that we're going to need to do to make sure that we capture. It's something that's helpful to know when you're negotiating with the payers. Remember, they already have this data. They're paying attention to it. We need to level the playing field with them and start paying attention to it as well. What if, in the previous slide, the example is, what if you did 200 total meets for Blue Cross every year, and they come when it's contract renewal time, and they want a discount based on the volume that they're sending your way? What if your response is, well, your patients are HCC scores are 8% higher than my United patients. That means they're more likely to develop a post-surgical complication. They're more likely to be readmitted. They're more likely to take up more of our practice's time, and we want to take care of those patients, but we can't give you a deeper discount than what we've already got in place. Right? You see how that shifts some of the balance of power there with the payers? They have this data. We need to make sure that you have it too. So there are lots of changes coming up with MIPS. We've had lots of changes in the meaningful use era. We will have more changes as we make the shift from volume to value as well. But I want to make sure that we take some of that control back. How do we find a win? Well, here's a win that's been given to us by CMS. In 2017, it's a transition year under MIPS. That means it's very, very easy to just submit something and avoid the negative adjustment. SRS has done, Lynn has done some great webinars, some great teaching on this. I won't belabor this point, but there's a lot of good information out there, and MIPS lets you choose which places you want to participate in and which ones you don't. And let's take advantage of that flexibility. Let's find some places where you can have some wins for the practice. We kind of been in a drought here with all the government change. We need a win. And let me show you what we think that might look like. How do we get a win for your providers? How do we get a win for your revenue cycle staff? This is what we've done with SRS. Remember this slide? We talked about it before. You most likely have people in your practice that the doctors are capturing that data. They're giving it to somebody on the office staff who has to put that information into the practice management system, has to put it into the EHR. How do we turn that into a win? Let me show you what we've done. Here's the workflow. Clinical staff can keep doing exactly what they're doing today. No change for them. That's a win. Coding and billing team can use Capture instead of keying that into the practice management system. Capture is an electronic super bill. I'll show you how it works. But by doing that and leveraging the APIs that SRS has created, we can automatically put the diagnosis codes. We can automatically put the visit codes into SRS so that we don't have to do duplicate entry there. That'll save practices almost 10 hours a day of staff time. And then on top of that, that's a win for the coding and billing staff. I only have to do that one time. But on top of that, remember how I said when you're doing the charge entry to the practice management system, you're looking for those coding mistakes. You're cleaning things up, making sure that they're done correctly. On top of that, there's a tool called Smart, and what Smart does is it reviews all of that data. It finds those problems for you so that you don't have to look at every single one of them. You only look at the ones that have a problem, and you can prevent denials before they ever happen. You can find missed revenue opportunities to make sure that claims are paid completely and correctly the first time. That's a win. That lets us give you better revenue cycle outcomes with less time spent to do that work. All right, so let me show you how it works, because it's very, very easy. What we do is we work with your practice to customize an electronic super bill. It looks just like the paper super bill. We can do that down to the subspecialty, specialty, down to the provider-specific level if you need to. But it's pretty simple and pretty straightforward. Got a level 3 office visit. I flip over to the back side, right? Maybe I've got osteoarthritis of the left knee, right? When I hit save, yes, I want to go anyway. When I hit save, what it's going to do, it'll automatically transfer that information into SRS. What I'm going to do is I'm going to hit refresh on this. When I hit refresh, you'll see the diagnosis, you'll see the visit type come in. Let me expand that example just a little bit more. Let me say, you know what? It wasn't a level 3, it was a level 4 office visit. And not only do I want to code osteoarthritis to the left knee, I want to get a little pop-up that shows me my most likely HCC comorbidities, so that I can say I do have morbid obesity, I do have hypertension, so that I can accurately reflect my patient acuity. Now when I'm done, again, I hit save. I can see a summary of everything that's been selected. There's a lot of cool stuff that I can do in here. But when I come back into SRS and I hit refresh, right, you'll see today's office visit has been changed to the level 4, and you'll see those other diagnosis codes have been added for the patient in SRS. So I can put that data in one place rather than two, and that's a win for my staff with no change for my physicians, no change for my PAs. And lets me put that data into the practice management system through an HL7 interface, into SRS through an API at the same time. Right? Now, some people are saying, now wait a minute, if you've got an electronic super bill, couldn't I put that in the hands of the doctors, in the hands of the PAs, in the hands of the scribes for some practices? Answer is absolutely. That's what a lot of our clients do. And that's how they can maximize that return on investment. They take out the paper super bill. They lose some of the cost there. They don't have to have staff key that into Excel capture, right? But for a lot of you, that may be a second step, right? Let's take the first step. Let's get an easy win now that doesn't require any physician change. And after doing that for 6 months, you want to slowly transition that over to your doctors? No problem. That's an easy thing to do, an easy step to take to pick up some additional return on investment. But you don't have to do that from day one. You don't have to do that from day one. You can, but you certainly don't have to. You've got options here. Let's get a win for the practice. We need one of those right now. So what happens in ExceloSmart? ExceloSmart is really a tool for my revenue cycle employees, right? It allows me to make sure that we're getting everything coded correctly and completely the first time. I pull in a batch of charges, and I can look at all of those encounters and only stop and check the ones that have problems. That exception-only workflow allows me to be very productive, right? We find typically one revenue cycle employee can handle about 165 encounters an hour. That certainly depends on the number of changes that you make. If you have to make more changes, you're going to be a bit slower. If you have to make fewer changes, you're going to be a bit faster. But that level of throughput allows me some additional time in my revenue cycle to make sure we're doing the other things that we need to do. Right? That helps us prepare for the value-based reimbursement world. Right? Because when we went and started having to add all this new information in because of meaningful use, you probably didn't get extra employees to do that. Right? Everybody just had to work harder. Everybody had to work faster. We're trying to give you some room to breathe so that you can be prepared for some of the changes that are coming down the road. And we can help you capture better data as well talk to you about some of the ways that we can help capture some of that HCC information. We want to prevent denials before they ever happen. If we can identify them here, build in things that are specific to your payers, to your providers, to your locations, right? The sticky notes that people know in their heads, we can build that into ExcelisSmart so that we make sure that that gets paid completely and correctly the first time. Some of our best clients, what they like to do is we work with them to build in rules that look for missing revenue opportunities, right? Whether it's, I'm looking for some of the DME that we don't bill for, that gets left off the charge ticket from time to time. Did we bill for the X-ray? Did we bill for the casting supplies that went along with the cast application, right? If I've got a payer that lets me bill for those separately. And we also work with our clients to look at some advanced revenue cycle analytics, to shine a spotlight on what changes are being made, which users are making which changes most frequently, so that we can help share those best practices within a client's revenue cycle team and also across clients, so that they can work as efficiently as possible in ExcelisSmart. Right? That's how we have a win, not only for our physicians, not only for the practice from a return on investment standpoint, not only for the charge entry process, data entry process, to the practice management system into SRS, but also for your revenue cycle teams. We prepare for the inevitable shift from fee-for-service to value-based reimbursement, right? The meaningful use arrow is hard. We're going to have more changes coming down the path with MIPS. We think this is an easy win that is well proven with other SRS clients. Again, I've been talking about a 15-provider practice. Let me show you just an example of what that looks like. I know I got a lot of numbers on this slide. I apologize. Happy to share these slides with anybody who needs them afterwards. But for a 15-provider practice that sees 450 patients per day, clinical teams using a paper super bill today, with that first workflow that I showed you, there's no change to the clinical team. That's huge. We can save that practice over 300 hours of data entry time every month. Right? That's $3,700 a month in time savings. Most of our clients see at least a 2% improvement in their denial rate through that process in ExcelisSmart. We can save $4,900 a month by preventing denied claims before they ever happen. If there are missed charges, this is the trickiest one to find, because if you knew what you were missing, you wouldn't be missing them. But even if you take that one away, the savings are significant for a relatively modest cost of the software. So for a 15-doctor practice, they're saving over $8,000 a month. That's nearly $100,000 a year in well-proven savings with no change for the clinical staff. That's a win. That's a big win. And a lot of this is possible through the API development work that SRS has done that allows us to send that information back to SRS in real time. That's something that just went live in January. What we've been hearing from some of the first clients that have gone up on that, they say their people are saving 2 minutes per encounter all day, every day. And that's only by adding the API part, right? They already had a tremendous return on investment from implementing White Plume years ago. But adding in the API saves them an additional 2 minutes per encounter all day, every day. Now, as a part of the partnership with SRS and as part of the new launch of the API, we are still offering for new clients who sign up in the first quarter, so by the end of March, which is a few weeks away, the first 2 months for free. So if anybody's interested in taking us up on that offer, we'd love to have you join us. We think that is a tremendous opportunity for practices, and we think, you don't have to take our word for it. Since 2006, we've been working with over 40 SRS practices across the country. So this is being used by over 1,300 providers. Most of them have their clinical staff that are using Accelicapture. However, some have billing staff, coding staff that are doing that. I would recommend, I think it makes a lot of sense to do that step one, right? To say it's no change for the physicians. That's a win for them. A huge time savings for the practice, right? 300 hours a month for that 15-doctor group. That's a win. It doesn't require a lot of risk, and it's been proven with over 40 practices. Right? There aren't many places where you can find something like that. And so I hope that is at least an interesting idea for you. Each practice is a little bit different. We would love to spend 30 minutes with you individually, on the phone or on a GoToMeeting, to give you a more detailed demo, show you how it works, talk about what your practice management system is. We've got interfaces with over 42 practice management systems already on the shelf, ready to go. So for most of you, that's probably available already. And to kind of give you some more detailed pricing, talk through the process with you. But I think if you feel like you've been in a high change environment and that your practice could use a win, if you could use a win with your doctors, bringing them something that can save the practice a significant amount of money with a pretty low risk, well proven solution, I think that'll be 30 minutes of your time well invested. So I'm happy to spend that time with you or connect you with our sales team, the sales folks in your area, to talk about that as well. Thank you. Thank you for your time. Thank you for paying attention and joining us this afternoon. What I'm going to do is I'll try to open up that questions panel and answer as many of those that I can.